Thank you. Good morning, ladies and gentlemen. I am thrilled and honored to be here, and even more thrilled that my dear friends that I've worked with at Jefferson provided that introduction. This morning I get to speak to you about a topic for which I have tremendous passion and believe that we as anesthesiologists have an important role, if not a primary role, in the management of patients with opioid use disorder. So in the few minutes we have to provide you some structure as to what may otherwise look like a disjointed talk, I want to talk a little bit about how we got here and just attitudes toward opioids, a little bit about how the way we do our anesthetics may actually fuel worse postoperative pain and increase opioid requirements. A touch on buprenorphine pharmacology, because I think it's a very misunderstood drug. And then the real nuts and bolts, what we can do, and to quickly look at the high points of the multi-society buprenorphine guidelines that we published last year. A little bit about advocacy, and then open for questions and to really get your take on this, and if you think this is something that should be with your society and if you would want to participate in future projects. So, cool, it works, thank you. I do have conflicts of interest. I've essentially worked on every drug developed in the acute pain and anesthesia space in the last 30 years. Fortunately, none of them have anything to do with this talk, so don't worry about conflicts of interest. Yeah, it doesn't matter. I was the last author on the buprenorphine guidelines paper. I present that as a potential conflict of interest if you believe that would be. So where does it start? I love this picture. I had a former partner when I was in private practice who had an addiction problem and would literally salivate if he saw a picture like this or large quantities of fentanyl. We are, I believe, a very opioid-focused society. That is the U.S., and I do believe we have a very misplaced sense of how useful and how potent opioids are. I've been doing pain management for probably 35 years, more, and each year I become less convinced that opioids have a benefit compared to other agents. They're just another agent, and I find many other analgesics to be far more powerful. So this paper by Chad Brummett was, for me, an eye-opener. It's relatively recent, but it looks at patients who are opioid naive, who have surgery and then have access to opioids. It's a retrospective review prior to tightening the reins on opioid prescribing. And what Chad was able to show is that between 6 and 10% of patients who have surgery will still be on opioids 6 months later. That's pretty absurd. So he further breaks it down to major and minor procedures. So you see the more minor procedures on the top, major procedures below. And there is no difference in the potential for persistent use. So this tells me it's not about pain. It's something more about the likability of these drugs, and that if we give patients essentially unfettered access postoperatively, are all of these patients technically addicted to opioids? Probably not, but they're probably dependent, and they nonetheless like them. This is not a good thing, and I don't think we've fully appreciated that potential for chronicity. So the question is, how many days of prescribing does it take before you're likely to see a signal that a patient will use opioids a year later? Another shocking statistic, this is big data from the CDC, it's 5 days. Once your opioid prescription is more than 5 days, there's a signal that patient is at risk for using opioids in a year. Again, does that mean that they are, down out opioid addicted? No. But there's a likability, and the longer you have opioids postoperatively, the greater the risk that there's going to be chronic use. And we do know that some, if not many of those patients, may go on to persistent use and opioid addiction. So it's all about personalized medicine and perioperative medicine, and we are now more involved in the preparation and the follow-up and the warm handoff. What should we be looking for? Well, patients with anxiety, catastrophizing, oh no, this is terrible, everything is going to be awful, chronic pain conditions, any psychiatric or mood disorder, any history of other substance use, tobacco, sleeping problems, even a remote history of opioid use. These are patients that in the preoperative interview, you have to have that moment of acknowledging that there is potential risk and that we're going to try other things. We're going to try a multimodal, non-opioid anchored approach. So one of the papers that really was that aha moment for me was this Cochrane review by my friends at Oxford, Danny Moore and Henry McQuay, first published in 2010 or 2011. And this is the updated version. And what they did is they took all the prior Cochrane reviews and essentially all of the world's literature on single-dose oral analgesics, converted it to numbers needed to treat to get a 50% reduction in pain. So basically, you end up with a really nice comparison by NNTs as to the potency of drugs. And here is the shocker. The best drug with an NNT approaching 1 is atoracoxib. That's a COX-2 inhibitor similar to Vioxx, rofecoxib, that is available all over the world, but not in the US. And if you ever travel outside the US or you have non-US colleagues, ask them about rofecoxib. It is absolutely an amazing analgesic. The worst drug is codeine with an NNT of like 8.5. Basically, it doesn't work. Codeine provides almost no analgesia. But the shocker for me, if you just kind of stand back, is that the general NNT for all these drugs, whether it's acetaminophen, paracetamol here because this is non-US, all of the NSAIDs, the NNTs are in the 2.5 to 4.5 range. And the real shocker, if I can get my pointer to work, I don't think I can, but right in the middle, do you see paracetamol, oxycodone, 600, 650? That's 2 Percocets. So the NNT of 2 Percocets is basically the same as the NNT for the acetaminophen alone. So what's the oxycodone doing? Okay. So this for me was really the eye-opener that oxycodone doesn't look really like it's any more powerful than the NSAIDs and the COX-2 inhibitors. I can't get it to, it's fine. I don't need the pointer. So aha moment for me. Okay. So now let's turn a little bit to how we think about our anesthetics. I'm going to show my age because I might be the oldest person in the room. No. I trained in the very early 80s at Penn, and we had the old guys and we had the young guys. The old guys hated opioids. They would not use opioids intraoperatively, and you could only use them in the PACU. The young guys would use lots of fentanyl. This was the new drug, and we were starting to do these nitrous narcotic anesthetics. And frankly, the patients all looked the same to me. I couldn't tell the difference in the PACU. But we became very dependent on high-dose opioids. I reviewed this paper in the late 90s. It was from the Canadian Journal, and I thought they had flipped the tables. What the authors had done in a GYN model is they either gave patients fentanyl in the operating room or they gave them esmolol. And then they looked in the PACU at their postoperative pain and opioid use. And guess what? Patients that got lots of fentanyl had more pain and more persistent opioid use for 72 hours. And I thought it was a mistake because back in the 90s, we thought, let's give lots of opioids, they'll have better postoperative pain. Not so. Then Collard did a similar study in the early 2000s with Lapcolis, where he gave patients either esmolol intraoperatively, fentanyl, or remifentanil. And then in the PACU measured their fentanyl pain requirements. Surprise. If you used remifentanil, you had more than twice the opioid requirement as if you had used no opioid at all. So something is going on. The use of opioids intraoperatively creates hyperalgesia and acute tolerance. And the signal is consistent that it exacerbates pain and causes higher opioid requirements. And I didn't put the slide in this talk, but there is a wonderful paper by an author whose name I'm forgetting, who looked at the needs for opioids and basically says, why do we use intraoperative opioids? Are we treating pain? These patients are unconscious. We're treating autonomic responses. And as such, we really should be thinking of using vasoactive drugs. We should not be thinking of using drugs like opioids that have huge ramifications. I'll think of his name before we're done. So if you really want a great summary of this, the Hayhurst Review paper in anesthesiology is a wonderful summary of all the evidence we have that shows that every molecule of opioid you use intraoperatively essentially creates hyperalgesia tolerance and increased opioid requirements in pain postoperatively. It's a wonderful paper. It's outstanding evidence. Please think about it. Please take a look at it, because it may change your thinking on the way we have done and the future of how we will do our anesthetics. Okay, so let's turn to the opioid crisis itself and think of where we are and why do we need to think about it. I truly have colleagues, not the Hufnagels, but other colleagues who say to me, why should I care? I didn't become an anesthesiologist to deal with these awful patients who don't care about themselves, and on and on. And some of them are actually on my team to make matters worse. The U.S. is less than 5% of the world population, but we use about 90% of the world's opioids. That's very out of balance. And we don't particularly have better outcome in pain and postoperative settings. Let's look at the cost. So even if you don't care about these patients, which I'm going to assume you really do, the cost of caring for patients with opioid use disorder 2 years ago, when the data was last put together, was over $500 million. Over $500 billion. To put that in perspective, the Medicare budget and Medicaid budget at the time was only about $100 billion more than that. So just caring for this population alone, we're spending as much of our healthcare dollar as we are on Medicare, the care of the elderly, and the care of those who are uninsured. It will bankrupt the system if we don't get control. We all have to participate in this. About a third of patients with opioid use disorder will terminate their care early and leave the hospital with incomplete treatment. Moreover, currently, we all deal with this. It's about 15 to 30% of our patients have opioid use disorder. Surprisingly, 40% of them, it's not recognized while they're in the hospital. So you're seeing these patients and you have no idea that they actually are suffering with addiction. So last year, data ending April of 2021, more than 100,000 Americans died of opioid overdose. So putting that in perspective, that's about 300 and some patients a day. That would be like a large commercial jetliner crashing every day. That would be headline news, and yet nobody talks about this. You don't see the mainstream media covering this. It's not the top line question of the day. Why is that? This is the catastrophe of our day, and nobody is looking at the causes, the root causes, and trying to fix it. we all have to be part of this. This is a crisis of a proportion. Someday we'll look back on this time and it will be like, oh my God, how could we possibly have ignored this and allowed it to happen without making it our number one policy issue of the US government and of the American people? Surprisingly, 75% of opioid deaths occur in the home. Shocking, right? I have a friend who's a cardiac anesthesiologist at Penn, Bonnie Milas, who lost 2 sons to opioid overdose in her home. She is a profound advocate that we should all carry intranasal naloxone and have it in our house, because it may not be your children or grandchildren. It could be the neighbor's kids who just bring in one of those look-alike pills. They don't know what they're doing, and there's a catastrophe. So one takeaway today is explore getting the intranasal naloxone. It's easy to use. It's essentially free. Most pharmacies will give it out. We actually give it out to every patient pretty much who leaves the hospital with an opioid. If you have insurance, we'll take your insurance, but you don't have to have insurance to get the nasal spray antagonist. Majority of the deaths are the fentanyls, or the so-called frankenfentanyls, that come from China. They're really adaptations of fentanyl. They're not our drug that's medicinally used. It's powder. It can be compressed into tablets. It can be snorted. It can be injected. We know the source. It's from China, and it's virtually all crossing the southern border without any control. Takeaway point number 2. We have an open border for drugs, and it's killing over 300 people a day. So, quick, answer this question. Does the war on drugs work? Everybody says no, right? But yet, what did we do a few years ago? We conducted a war on opioid prescribing. And if you look at the only line that's going downward, that's the success we have had convincing our fellow physicians to reduce opioid prescribing. So we actually had a war on prescription opioids. Did it work? Actually, it did. We don't really see much in the way of pharmaceutical opioid abuse or death. It's all from these illegal drugs. Virtually all of it is from illegal drugs. And now you can see the major increase is the synthetic opioids, which it's almost all fentanyl at this point. Heroin is leveled out because heroin isn't cheap enough to produce, and it doesn't give quite the high that fentanyl and the frankenfentanyls provide. And it's a constant moving target. They're constantly putting new types of drugs. So now xylazine, benzos are starting to appear routinely. So a pause to talk about what is addiction. This is the formal definition from the American Society of Addiction Medicine. And the takeaway are the italicized words. It's a treatable chronic medical disease. So it is treatable. Opioid addiction is absolutely treatable, and it is a chronic medical disease. It doesn't go away. So when you have a patient who said, 10 years ago I had a problem, or 3 years ago, no, they still have a problem, and you must treat them very differently with exposure to the likable drugs than you would somebody who is, totally opioid naive. The other thing I want for you to take away is the intense stigma that these patients deal with. So what's stigma? It's negative attitudes, beliefs, actions, and we all say, I don't stigmatize them, I take care of them. But the reality is the system stigmatizes them. What other medical illness requires you to stand in line for treatment every morning at a special clinic that says, methadone, right? Or if you are fortunate enough to get buprenorphine, you need to find a prescriber who has their X waiver. They're typically not going to be your family doctor. It's not going to be mainstream care. So we isolate it from mainstream care. They can't get this in the context of their other medical treatment. And it's sort of like, yeah, there he is, that person has an addiction problem and they have to stand in line for the treatment. It's dehumanizing, and I think until we can make the treatment of opioid use disorder mainstream and get rid of the X waiver and basically allow all of us to prescribe buprenorphine in an outpatient setting, it worsens the situation and it creates barriers that make it very difficult for these individuals to seek treatment. We set them up for failure, essentially. So what are the current treatment avenues? Well, we have 3 approved drugs: buprenorphine, methadone, and a variety of naltrexone products. The hallmark has always been psychiatry or psychology, group therapy. But the reality is that without the chemical treatment, which is now referred to as MOUD, medicated assisted treatment for opioid use disorder, that's the new term. Without drugs, these patients have a very reduced opportunity to get into a prolonged recovery. I don't do psychiatry, I don't counsel patients, but I know how to start buprenorphine, and it's easy to do. And before today is over, in the next hour, you are going to know how to do this, and I'm going to urge you to be eager to take this on and see how well it works. So where do we intersect with this? We get patients every day in the OR who are either already on buprenorphine, and we have to decide, do we keep them on it or do we stop it? Or we get patients who have opioid use disorder and they are the train wrecks and they can just get through our OR, or we can, as perioperative physicians, figure out how to get them into treatment at a later time. And that's really, what I want you to take away today. So a little bit about the pharmacology of buprenorphine. It's probably not the buprenorphine we thought it was a few years ago. The drug is considered a partial agonist. What does that mean? Well, technically, the definition of a partial mu agonist is that it has a ceiling effect. But the reality is, we now understand that every opioid has a ceiling effect, and we overdose patients all the time. So, quick question and fun fact: what is the morphine milligram equivalent ceiling effect for all opioids? Like milligrams per day. How many milligrams of morphine a day to get to that ceiling effect at which you don't see further benefit? Any ideas? Anybody want to take a guess at it? And we're talking oral morphine. I know it's hard to get takers at 7 a.m. It's 100 milligrams a day. So 100 milligrams a day is roughly like 10 of oxycodone every 4 hours, which is a standard dosing regimen. How many patients do we see who are on far, far more than 60 milligrams of oxycodone a day? But I would be hard put, if you look at the world's literature on opioids, it is almost impossible to find evidence that more than 100 milligrams of morphine oral a day provides better analgesia, but we do it all the time. So I personally think that term partial agonist is going to go away in a few years. It's a vestige of an idea we had. Why is it clear that buprenorphine reaches a peak analgesic effect? It has an incredible binding affinity. So it saturates the receptors very quickly and it reaches its peak analgesic effect, and you know what you're dealing with. You can actually calculate the number of receptors that are occupied, and it's really useful information. The other thing is buprenorphine is a kappa antagonist. Why is that important? So all of the other opioids are kappa agonists. Kappa agonism causes the euphoria, the dysphoria, and the depressive effects that are part of that cycle of addiction. So even with chronic pain patients, when I convert them to buprenorphine, within about 48 hours, they brighten up and they say, I feel like a cloud was lifted. I feel like I used to feel. I don't feel depressed. I'm happy. that's part of the treatment benefit of buprenorphine. These patients lose that depressive cycle of other opioids. Can you precipitate withdrawal with buprenorphine? You sure can, because it's such a high binding affinity, it displaces other opioids. But that's only if you have a bunch of other opioids and if you give a large dose of buprenorphine. One of our addiction specialists says, if you come to me and you're feeling bad, I'll make you feel good, right? If you're in withdrawal, I can treat you with buprenorphine. But if you're feeling good, then I'll make you feel bad because I'll cause withdrawal. But the surprise is how analgesic buprenorphine is. In treating opioid use disorder, we use milligram doses, like Suboxone, Subutex, and we'll give 8 to 16 milligrams a day. Purely for pain management, a Butrans patch gives about 10 micrograms of buprenorphine an hour. And it's incredibly analgesic. So, this is a drug we really need to rethink as a first-line agent, and it does not have respiratory depression, it doesn't have the nausea and vomiting, it has a much, much more tolerable adverse event profile. So, if you have a patient on buprenorphine, do you continue or discontinue? You continue. Today, the first-line thinking is there's no benefit to stopping buprenorphine, and you're likely to cause that patient to go back to taking opioids. So the McIntyre paper is one of the best references where they took patients on either methadone or buprenorphine. They discontinued it in half of the subjects and they continued it in the others. And what they found is there was no difference in pain relief. So if you think patients are going to get better pain relief off of these drugs, it's not true. But what they found is patients used tons of IV PCA. And then the kicker is more than half of patients who are taken off buprenorphine perioperatively go back to using opioids. And they are at high risk for death because they're not as tolerant at that point. So continue buprenorphine. Takeaway point, very important. So when you're trying to block the receptor, the question is, when is that receptor blocked? And the reality is we can actually calculate that pretty well with buprenorphine. So you have access to these slides. I gave you a lot of data from a number of authors who've looked at this. Be wary looking at the Greenwald articles because he looks at receptors available versus receptors occupied, and the other three boxes are different. They're receptors occupied by buprenorphine. But I can summarize it. If your patient is on 8 milligrams of buprenorphine a day and Suboxone, you have about 75% of receptors occupied, which means you still have a lot of receptors. So you could give standard PCA, you could give more buprenorphine. There's a bit you can do with those remaining receptors. Once you get about 16 milligrams a day, you're between 85 and 95% receptor occupied. So you're dealing with a lot fewer receptors. Now, in terms of pain management, what does that mean? Well, once you get to 100% receptor occupancy, there's no better analgesia. It's not like you're going to provide better pain relief by giving more. You're done with opioids. You have to think of other drugs. So what drugs do we think of? Well, the only drug that has a higher binding affinity is sufentanil. Sufentanil will actually displace buprenorphine from the receptor. And this is the drug I would use in the operating room in dealing with these patients. And I have used it as PCA, and we've used it in the unit, and it certainly works. Supposedly it's on back order until July or something. It's ridiculous. But I would urge you, when this drug comes back, think about this being your primary drug. Another interesting thing about sufentanil is that it has a very high, it's the highest intrinsic efficacy of any opioid. What does that mean? You only have to occupy 50% of your receptors to get 100% opioid effect. So if you give more than that, you're just going to cause hyperalgesia and tolerance, and that's typically what we do. So small amounts of sufentanil are actually incredibly effective. So perioperative buprenorphine, continue it post-op. If you need to increase the dose, I'll increase it up to 24 milligrams a day. It's a very, very analgesic drug. If buprenorphine doesn't work, then you need ketamine, you need non-steroidals, you need every other regional technique in the book, because opioids are not going to cut it. Ketamine is an incredibly effective drug. Not only is it a potent analgesic, but it reduces opioid withdrawal, along with clonidine. And I'm going to hit that term warm handoff a few times. If you do all the right things and you do not have the communication to the buprenorphine prescriber, things are not going to go well. You really have to set the stage for success and say, this is what we did, this is the dose, and now we all agree, the patient and you are going to manage this. Giving opioids to a patient in recovery is like opening the gate, and it's not a fuzzy, warm, or cold dog nose. It's the ugliness of opioid addiction, and again, many of these patients die. If that isn't enough, I can tell you that there were a rash of wrongful death lawsuits against physicians last year who stopped buprenorphine. So if you stop buprenorphine, and that's under your name, you've documented that in the chart, and that patient dies of an opioid overdose, you may see a wrongful death lawsuit coming your way. Keep that in mind. So why are patients likely to convert in the hospital? So they're often homeless, they're on the street, they've been opioid addicts for years. How am I going to change this? Well, many of these patients are with us for weeks, sometimes months, and they're often receiving ketamine, and they get a lot of kind care. I promise them they are not going to suffer withdrawal. We work very carefully to keep them out of withdrawal. And they really, they'll gain your trust, and they fear terrible outcome. It sinks in that they almost died, and they are open to the idea. So after several days, these patients will often say, I think I want to try it. So we have a group within the hospital. In our place, it's called NARPS. It's actually really social workers who come and make sure that they're committed, talk about, do you want morphine, methadone or buprenorphine? And they hook them up to a program to assure that if they accept treatment, they absolutely have a follow-up. So thank God I don't have to deal with that. All I have to do is get them to accept it and start. So I find it's worth it. I talk to these patients every day and say, do you want to try? Do you want to try? And it's amazing the number of patients who will go for it. So, okay, so pause. When I began my ASRA presidency, I had the gift of working with then Surgeon General Jerry Adams. He's a wonderful, wonderful person. He's an anesthesiologist. And he poked at me the day I became ASRA president and said, can you form a group to look at what anesthesiologists can do in the opioid crisis? I was like, well, yeah, right now we're treating. He said, okay, do it. Get ASA, get as many societies. I'm now kicking myself that I didn't invite your society to this. But we did get ASA to pain societies, the Society for Addiction Management, and the Big Pharmacy Society, and we crafted guidelines. And the basis of those guidelines, by the way, I have to commend Lynn Cohan, who I appointed to chair that project, did an outstanding job. This is an open access paper. Please get it, please read it, because it gives you all of the recipe for how to do this. It arms you with everything you really need to know as an anesthesiologist about opioid use disorder. If you have trouble getting it, email me. I'll send you the paper, but it's free, it's available. But the two takeaways were, if your patient is on buprenorphine, don't stop it. And all the evidence is there. If they're not, do everything you can to get them onto buprenorphine, and this is how you do it. So why is it so critical for us in the hospital setting, or when these patients intersect with the healthcare system, why is it so important for us to get them into treatment, preferably with buprenorphine? Because the highest incidence of death is in the first 28 days after hospitalization. I mean, look at this, it's staggering. And we see it. I mean, we hear about these patients who leave against advice, and then we find out that they've passed on. So this is a really major event in their lives that if you can interact and even get them onto buprenorphine for a month or two, you have potentially saved a life, and there's an opportunity for another day. So another takeaway. So buprenorphine decreases morbidity, mortality, even in the short term, and it's a chance to save a life. It's easy to use. We're in a unique position as perioperative physicians to lead this, to drive this, and to get patients to convert from whatever other opioids they're currently taking to buprenorphine. And I can do it in a day. It's something we can all master. Well, a lot of my peers say, well, yeah, but they're only going to go back and use opioids. How many times do patients enter recovery before they're likely to stay in recovery? Any ideas? Like 8 times. So if a patient says to you, doc, I've already tried 4 times, it doesn't work for me, I say, man, you're halfway there. Keep at it. If you keep at it another 4 times, you're going to be in permanent recovery. So you be supportive, you do what you can, and eventually it works. It may not be that time, but you may save a life. So how do we do this? Basically, I get their consent. I get not written consent, but I get their agreement. They have to want this, and they have to really buy into it. You can't force people. I've seen our psychiatrists force people to take buprenorphine, and it is always an S show, if you know what I mean. So what do? I turn off their PCA for an hour or 2 and give them PRN, buprenorphine, 2 milligrams, and I let them titrate every 1 to 2 hours up to a max of 16 milligrams. And everyone told me, you're going to put them into withdrawal, it's going to be horrible. No, there is no withdrawal, right? When we treat opioid side effects with naloxone, what do? We dilute it and we give tiny, tiny doses. Do we cause withdrawal? Of course not. If somebody has pruritus, I can stop that with a tiny dose of naloxone. They don't all go into withdrawal. I can do that same thing with buprenorphine, and I give it in little doses, but I'm there, we hold their hand, we say, okay, if you're in withdrawal, we'll stop, we'll do something else. We never see withdrawal. The other surprising thing is, even though they have access to basically as much buprenorphine as they want, rarely do patients request more than 8 to 12 milligrams that first day. They're not in withdrawal, and they have equal or better analgesia than they did on standard opioids. They're happy. And then the second day, I empirically put them on 8 BID because I want to block them. I want to get them ready to go out and get into their program. See, you can do that. It is so easy to do that. And if you want to chat during the break, if you have reservations, if you have questions, but it is painfully easy. There's infographics. We published this. One of our residents actually had the privilege of publishing our first case series, but it's painfully easy. That article has a lot of the details. So buprenorphine is life-saving. What's the numbers needed to treat to save 1 life? 2.5. So if I get 3 patients started on buprenorphine, I've saved 1 life. What else can you do in medicine that has that potential to save life? There's nothing. I can't think of any intervention we do that has an NNT of less than 3. So this is that rare moment when you can actually save lives. So as I kind of summarize, when you deal with these patients, when they come back, this is your opportunity to really create that personalized medicine for these patients. You screen them, you have the opportunity to derail active addiction, or you can educate them on staying on their current treatment. You can optimize their care, optimize their analgesics, because very often their treatment programs don't actually do that. They're just focusing on the addiction. Talk about multimodal. You have to tell them that opioids aren't going to work. You have to have multimodal, regional, and all these other drugs. And extensive considerations for transitioning them back to their home regimen with their addiction treatment, and then the all-important warm handoff. You have to have that connection. If not you, the surgeon, somebody has to be able to go to that prescriber and say, this is what we did, and they're doing okay, this is what you have to do. So in summary, actually 2 summary slides, we're going to deal with this for many, many years. The crisis is not leveled off. And currently, the border is more open than ever. The amount of availability of cheap, incredibly powerful and dangerous drugs is exploding by the day. And worse yet, the contaminants keep increasing. So the new one now is xylazine. This is a horse tranquilizer. So while I can treat opioid addiction, boy, xylazine addiction is really rough. These patients just are inconsistent withdrawal for a couple of weeks. Dexmedetomidine works, lots of clonidine, ketamine, but it's not like treating opioid addiction. The other thing we're starting to see is benzos. And the frightening thing about benzo contamination is that many individuals are never free from benzo withdrawal. So once you've had a long exposure to benzodiazepines, you may never be able to stop taking them without being in withdrawal. And we're starting to see this, which is really going to complicate the crisis, and who knows what next is coming. Remember that 28-day window. Our goal is to get them past that opportunity for death in the first month, and that's really where we need to target getting them into treatment, even in the short term. So we really need to point all of our attention to treatment there. Remember, buprenorphine is life-saving. And most important, remember, we have a huge opportunity as perioperative physicians and anesthesiologists in the operating room to make their lives better, to save them, to get them into treatment. I take that responsibility very, very seriously. And as this crisis increases, I think we all have to take this into consideration, or it's going to take down the whole healthcare system. It's not going away. And then finally, what else can we do? Well, number one, be advocates. Get to know your legislators. Go to their offices, talk to them. They have no idea what's going on in this crisis. They have no idea how critical the southern border is, about the free access. Legislators will give you all the money in the world for rehabilitation. They'll get tons of money for treatment programs. I don't need that. I can get patients into a bed at a rehab facility any day of the week. There's no shortage of rehab beds. The problem is the oversupply of opioids. We have to reduce that supply, or it's going to happen. Do you know about the Uber app of opioid delivery? I got to tell you this. So there's now, the cartels have figured out how to use the Uber software for delivery. So now you punch in your delivery app and you say, I'm at 11th and Walnut, I need 20 bags of fentanyl. And a runner will bring that to you in about 15 minutes. Now, that runner is only carrying your drugs. So we've decriminalized possession. So if that runner is caught, hey, these are my drugs. You can't arrest them, right? So we've seen the decline of criminal arrests for selling drugs. Is it a good thing? Is it a bad thing? Well, whatever the end result is, it has fueled this crisis. And the cartels who operate in many of your cities have figured out how to do this, and they are running the show. Educate your legislators about the X waiver, and educate yourself. So the X waiver is what you have to have as a rider on your DEA license if you want to be a buprenorphine provider. However, in the hospital, you don't need that. Anybody can prescribe buprenorphine. So it's not going to stop you, or there's no legal issue. But if you want to open a clinic, you need an X before your DEA number to have the ability to treat 100 patients with buprenorphine. We need to get rid of that. And actually the prior administration ended that, and the current administration reinstated the X waiver, much to the anger and frustration of many of us. 20 medical societies signed on, and the current administration is just not interested. They're not thinking about it. They're not. All they said is we'll waive the education requirements, but it's not on their target to get rid of the X waiver. Who can get rid of the X waiver? Well, the president can do it, or it can be legislation. So I've talked to the Surgeon Generals. I've actually had many conversations with Rachel Levine, the current Deputy Director of Health and Human Services. And Rachel says, they don't listen to us. We're appointed. You have to talk to elected officials. So that's what we're doing. Talk to them. Tell them get rid of it. They can pass the law to make it go away. And then the final thing I leave, well, almost final thing, is think about carrying naloxone spray. Think about having it in your house. You just don't know. 300 plus people a day. It may not be your kids or grandkids. It could be the neighbor's kids. It's cheap, free, readily available, and it could save a life, maybe a family member. And then the last thing I leave you with is I don't know if it's on your society's radar to think about this and make it an initiative. And I had to fight like hell to get it on ASA's agenda, because a lot of our peers there kind of said, are they going to pay me to do this? Why should I take this on? And it really kills me to think that we wouldn't do this because it's the right thing to do. But if it's something that we could get your society on board, then maybe at the next iteration or some of the next initiatives, then you could also sign on to some of the subsequent papers. And that's all I've got. Thank you for the invitation. I'm so honored to be here and to be able to speak to you, and we have a few minutes for your questions and answers. Thank you. It always takes longer than you think. I'm sorry, but we have a few minutes.
Quick question.
Yes.
So we've been using a lot of ketamine on our patients intraoperatively, frequently dosing to start with about a 0.5 milligram per kilogram and running them at about 1 mg per kilo per minute for the case. You said intra and post-op. I've never seen ketamine on a packing order sheet. Any way that you recommend or setting it up so we could possibly do ketamine in the packet?
Sure. Let me get my microphone working here.
This is going.
Okay. I think number 2 just needs to be. So I have number 1.
Okay.
Number 2. There we go. Oh yeah, I didn't push it. So yeah, ketamine is incredibly easy to use. It has a very wide therapeutic window. So don't be so concerned about the actual dose. I'm more concerned about like medication safety and drug errors. So the program I set up, we don't even do milligram per kilo. You can certainly do that in the OR. A 0.5 milligram per kilo pre-induction is a wonderful idea, but we generally just run an infusion at like 20 to 30 milligrams per hour. On the floors, we just run, we don't do weight-based. We'll start at 10 milligrams an hour, we'll increase to 15, we'll increase to 20, maybe to 25, all against side effects. And once patients start to have significant side effects, then we stop there and we make sure they have the clonidine patch and maybe a little benzo. So it's relatively easy to use. The adverse event profile is actually far safer than opioids. You're not going to see respiratory death from ketamine. Where'd you go? Does that answer?
But can you start it in a packet?
Absolutely, yeah. So we hopefully started in the OR, an infusion, and we just continue it. Sometimes we miss, how I said like 40% of them we don't know. So very often we get the consults either in the PACU or on the floor when it finally dawns on people that there's a history. And that's, we'll start it there. Easy to do.
Other questions? Yes.
If you have a patient with opioid use disorder and you're on morphine and they've been doing great for a couple of years, and they tell you
So I tell them that's not my job. That needs to be.
How hard is it to get off that?
Oh, well, how hard from the viewpoint of withdrawal or from the risk of going back to opioids? Okay, I primed you a little there. So the reality is that buprenorphine does have that very high binding affinity. And like any chronic opioid, get closer, can you hear me? Okay, so like any opioid, you will have some withdrawal. So I absolutely would say you're gonna have to taper that drug slowly and probably do treatment for withdrawal like clonidine. But you can get over that. It'll take a little while. But the real question is like, why do they want to get over the active treatment phase? Because it reduces craving, and it tends to keep them honest so that if they use, it's unlike methadone, I can cheat every day of the week with methadone because my receptors aren't blocked. But when you're actively using buprenorphine, you can put heroin, fentanyl, it doesn't work. And those individuals know that. So I would say it's legitimate over time to taper the dose down to about 8 milligrams a day. But I think if they're going to taper below that, there needs to be extensive counseling and that needs to be discussed. It's really a lifelong commitment, and there's no shame to being on buprenorphine. There's no tremendous side effects from it. Sure. Yes.
I have a comment. I would suggest that you add to your definition not just treatable, but incurable. Once an addict, always an addict.
I actually am not a psychiatrist or an addiction psychiatrist. I fully agree that once you have had an addiction problem, even if you are free of using drugs, it's still waiting in the background. But the American Society for Addiction doesn't like to use that terminology. I don't know why, but I agree. Yeah.
I suspect they don't like using it because they've fallen prey to this idea of using euphemisms. Covering up hard truths, we need to face with soft language.
I agree. I agree.
Any other questions from the audience? So I have one. In non-opioid addicted patients, for say a long spine surgery, what can I do to minimize the possibility that this patient will go on to need opioids and become addicted when they haven't had this in the past?
So you really make a huge case for those individuals who are having really long and painful procedures, who are likely to have prolonged pain. And you have to use every resource available to minimize your intraoperative opioid. So what do I recommend? Ketamine. There's outstanding evidence specifically in spine surgery that ketamine reduces not only pain during and after, but for months later. So just think of that. Something you do intraoperatively, as simple as using ketamine, may reduce pain and opioid use a couple months later, and we have that information for spine. The other drug that's really remarkable is IV lidocaine. IV lidocaine is a very potent anti-inflammatory drug. There's mountains of evidence in open bowel surgery, chest surgery, soft tissue surgery. So any place where there's a lot of irritation, manipulation of organs and soft tissue, running lidocaine will reduce that inflammatory response and improve postoperative pain and opioid use. Specifically, there are good papers in spine that show patients who have just intraoperative lidocaine have less pain, less morbidity, and better functional recovery at 3 months post-op, measured by SF-12. And it sounds crazy, but something as simple as running IV lidocaine during your case can have an outcome difference at 3 months. And then you throw everything else at them, post-op, non-opioids, local in the incision, COX-2 inhibitors, everything you can possibly throw at them, and minimize the opioids. Opioids are the PRN, the rescue.
Anything else from the audience at all? We have just a couple minutes left. Would you comment on people that are pregnant that are on medication-assisted therapy? Because the majority of them that we see are on methadone. I've seen that there's some literature saying babies are bigger when they're born when people are on methadone, but we rarely get people on buprenorphine.
Yeah, and that has to change. There's absolutely no reason why buprenorphine can't be used in the whole peripartum process. It's an extremely stable drug. My biggest concern with methadone are the ancillary complications, right? We've all seen the prolonged QT interval. We've seen patients arrest on the operating table. We've seen respiratory events. Tolerance varies. Metabolism of the drug varies in the postpartum period. So using methadone is a potential big risk. And as you look at the literature, there's no downside to using buprenorphine. It's just nobody does it. So I would actually challenge that space to say it's time that we start to do what the rest of the world of addiction has done and recognize that these patients feel better on buprenorphine and they can't cheat when they're on buprenorphine. There's no way to cheat when the receptors are blocked. All right, we've done it on some postpartum.
Now,
and they do well.
Is it an escalation of dose when you're pregnant like methadone or not?
It should not be because it's based on receptor occupancy. However, if you gave more than 16 milligrams a day, what's the harm? There's no tremendous harm to doing a higher dose, but there should not be a difference in dosing.
Okay. One more question?
Thank you for that excellent talk. That was wonderful. I have a question about methadone, and I specifically got up hearing your comment about the side effects, especially in drop. And there is a study going on, it's on clinical trials at Duke, where they're giving 20 milligrams of methadone to outpatients. And I believe our editor of anesthesiology is a big proponent of outpatient of use of methadone for ambulatory surgery patients, and I'd love to get your comments because, I've been eagerly waiting for that study to get published. It's been in the process for 2 years, and
So I think you're referring to this new wave of thinking that relatively small doses of methadone intraoperatively or perioperatively have a considerable analgesic effect in opioid-naive patients. And that actually is true. So if you're dealing with opioid-naive patients and you want to do something very simple that is going to improve their post-op analgesia, 10 to 20 milligrams of intraoperative methadone actually has a really good beneficial effect. Why is that? So methadone has an NMDA receptor antagonism. So I think in a lot of ways it's working like ketamine. What we don't have yet is a nice comparison study of 10 of methadone versus a half a milligram per kilo of ketamine to see if one is better than the other. So there's work to be done. I personally think ketamine is easier to use and perhaps more potent. But hey, I fully support the low-dose methadone in opioid-naive patients. I think
but you do endorse it for outpatient use, where you would give a single dose and send them home at the end of a relatively smaller procedure.
Right. So the thing to remember, how does methadone kill? Methadone takes 5 days to reach steady-state kinetics at a stable dose. So if I give 10 milligrams of oral methadone today, tomorrow, the next day, the plasma levels are rising. It's not that I reach my peak. So at that stable dose, I don't reach my full methadone effect for 5 days. If I do a single dose, there's no major risk. But if I'm prolonging treatment, you don't escalate. You want to see what the patient's side effect profile is at 5 days of a stable dose. That's the one route where we kill patients with that drug.
Okay, I think we have to wrap this session up. Everyone give Dr. Viscusi A warm set of applause. You did a great job. Wonderful lecture.
Appreciate it. Thank you. And if you have any questions about the initiation, I'm happy to talk to you during the break later.
Thanks for a super lecture.